Hi, my name is Christy Baldwin. I'm one of the HRO leads here at Eastern Kansas, and I'm also an Army veteran.
I'm Bob Devine. I'm one of the anesthesiologists at the Leavenworth VA, and I am a Navy veteran.
And I appreciate your time watching our video submission. And so to give you a little bit of background story, it was actually Dr. Devine's team here. He's part of the Leavenworth side of the house. So Eastern Kansas, if you're not familiar, we have two campuses, one in Topeka and one in Leavenworth. And they're about an hour apart. And so this is when Leavenworth OR was going through training. It was back in October of 23. And I know you had a special feeling about attending that training, didn't you, Dr. Devine?
I did. We closed the OR down, and I was driving up here for the training, and I had potentially the worst attitude you could imagine. I was grousing all the way up here in the car about how I had better things to do with my time, and I was so busy, and I was going to be sitting in a classroom all day. And full disclosure, I absolutely hate role playing, so I thought it was going to be a whole day of like trust falls. And obviously, I changed my tune shortly after watching the Elaine Bromley video, and I've been a master trainer ever since.
So actually, I think we talked about you being a master trainer right afterwards. And so to kind of tell you, I think you had 37 people who attended. We actually had to go off campus because we didn't have a place big enough in the Leavenworth. And so what really stood out to me during that training, besides you volunteering afterwards to be a trainer, was you had one of your EMS housekeepers, I think his name was Robert, correct? And he was the only non-clinical person, if I remember correctly, and he was really into the training, correct?
Yep.
Like
absolutely.
He was sitting in front of you, I think, and he was really into the training. And so afterwards, we had been batting around doing reshooting the 3Ws video that is shown in the training. And so I went up to Robert and I said, Robert, I just think you'd be amazing reshooting that video. And he was just really positive. He was just a positive person anyway. And I said, you have to know, you could get some grief afterwards, right? You could, be ribbed a little bit. And so I think you were standing there and he goes, well, I would never say that to a doctor. And we're like, Robert, that's what this whole training was about. And you stood in there, I think, and said the same thing. And he's like, well, I would never. I mean, that's not what we do. We can't speak up to doctors like that. And so I kind of said to him, I'm like, well, do you fly on the plane? And he's like, well, yeah, I fly. And my family flies. And I said, well, don't you want that baggage handler or, whoever, if they see something unsafe? And he's like, well, of course I do. And I said, well, that could be somebody's mom, right, that you're speaking up, for. And so he goes, wow, I didn't really think about it that way. And so we'd been batting around the 911 slide. I think we tried it out a few times, but I want to say it was really after that training. I thought, wow, we kind of put it in that context. So you put it really well earlier when we were talking. Can I explain why you think the 911 slide has added?
So the reason I think that this works is it gives you all these different well-known methods for basically calling out an emergency situation. And, talking to somebody about 911, people accept that, people understand that, people don't have a moral dilemma about calling 911 if they see something that's dangerous, and the same holds true for all of these. And so contextualizing the 3Ws with these accepted emergency recognizable methods for calling attention to something dangerous, putting the 3Ws in the context with these slides kind of demystifies what the 3Ws are supposed to be.
And I think you agree. I know you teach all the modules. And so, really since we've added it, we haven't got a lot of pushback, right? We used to get quite a bit. And granted, also our teams are more familiar that are going through with the 3Ws. And so, like I said, I appreciate your time watching our video. So the first part here that you're going to see is Dr. Devine just kind of modeling how we have done the training here with the addition of the 911 slide. We also slipped in the bystander effect, which was actually one of our social workers, Amanda Frederick, also a master trainer, that she started using that a couple years ago too. And I know not all of us use that, but really think it's added. And so we wanted to show how that could look, adding that also. And so again, I thank you for your time. Love your feedback on it. I guess our ask is for you to entertain adding this to the initial and refresher training moving forward. If not, we plan on still continuing on here in Eastern Kansas and sharing it within our Vision 15. And we will definitely be using this video for training purposes for all of our master trainers. So I appreciate your time. Thank you so much.
Thanks.
Okay, so we've talked about what the characteristics are of a person that we consider to be an effective follower. And so now we're going to talk about how we put that into practice. So I expect everyone in the room is familiar with 911. Yeah? Okay. Has anyone ever called 911? Yeah? Everybody? Half of you?
I've not.
Okay. Does anyone recall what we did? Well, none of you are probably old enough, but does anyone know what we did before 911 was a thing?
I think maybe that my grandma had a list of phone numbers,
Yep.
right? And so it was next to the, of course, that was back when we had a rotary phone.
Right.
And so, which was very stressful. And so I think like for sheriff and operator and stuff like that, if I remember.
Right. The default was you just called the operator if you didn't have the whole list on the wall. And the reason why, well, okay, so 911 was initially suggested in like 1968. Somebody thought it would be a good idea to have some sort of, standardized way to get a hold of somebody in an emergency. It became kind of a national standard in 1973, but there were still places that did not have 911 even as late as the 80s, like some of the suburbs of Chicago, right, a major metropolitan area, did not have 911. 911 was chosen because if you remember the rotary phone, if it was 999, that's 3 full spins on the dial, and so this was faster, 911. 999 is what they used in the UK. But at any rate, so are there penalties for calling 911? Do you get in trouble for calling 911? Not unless you're doing, like if you're swatting or something like that. That would probably have some negative ramifications. But this was instituted as a way to try and make it a universal response to an emergency. So you didn't have to, figure out what to do or call the operator, and then the operator had to determine who they were going to call. So there's no penalties for using it. What if you're wrong? What if there isn't an emergency? Nothing, no ramifications, right? You're just being a good citizen. So this is a little bit small, but this is explaining how to make a Mayday call. So I'm kind of a history nerd, as we've probably discussed previously. Mayday actually was instituted by a British pilot who had spent some time in France, and so this is a complete sort of mockery of French, not intentionally, but it comes from the French phrase "help me," which he kind of converted into Mayday, and so that's the same idea as 911. Mayday means my plane's about to crash. It was a response to the advent of radio communication. So this is what pilots would use if they were in jeopardy and they were about to ditch the plane. You say Mayday, Mayday, Mayday 3 times, tell them where you are, where you're going down, whatever. SOS, I presume everybody's familiar with SOS. What does it mean? What do we think it means?
Save our souls.
Right, which is not what it means. SOS was just something that was easy to use with Morse code. 3 dots, 3 dashes, 3 dots. First instituted in Germany in their maritime regulations in the early 1900s. Kind of became standardized around 1908, I think, and then first used in 1909. So well established, all 3 of those things, that people, recognize that as a signal that something's wrong. What is this? Right. Unlike the cartoons, most people that are drowning do not go 1, 2, 3 to signal this is it. Universal sign of choking, correct? Unless it's the first Wednesday of the month at 11 or 12 o'clock, depending on where you live. Amber alerts. If you got Amber alerts on your phone, they go off all the time. But as soon as you hear that tone, it's very distinct. It doesn't sound like anything else, so you recognize what it is. And then this one, I actually like this one because until probably 2 years ago, I had no idea what this meant, right? Signal that I'm not safe, I need help. So we recognize distress signals. For the VA, we recognize that safety is everyone's responsibility. And so we want to have some kind of method for bringing a safety concern to everyone's attention that's unique and distinct and cannot be misinterpreted. So we have the 3 W's. What I see, what I'm concerned about, and what I want. Now, the first time people hear that, they kind of look at me like, this is just weird. It is weird. It's clunky. It's wonky. It seems completely unrealistic for how people would communicate in any kind of a situation. But I would submit that the first time people heard about 911, they probably thought that was pretty weird too. And now it's just become commonplace. So the goal with the 3 W's is that when somebody hears you start to say the phrases, what I see, and then the follow-on, is that's going to get their attention because they're going to recognize that's the stop the line phrase. That's the indication that we have an emergency situation. You know, something bad could happen and I'm worried about it. So we know what makes up the characteristics of an effective follower. And so then we have the effective followership algorithm. I'll be honest with you, I would love to rework this slide because the way we talk about this is the progression from the 3 W's. If it doesn't work, we go to the 4-step tool, then we engage, then we use the chain of command. I would like that these kind of up arrows be a little more pronounced. The point is you can jump into this at any level. And so maybe that's why they chose to emphasize this take action that you can get in anywhere. And it doesn't have to be a linear progression. It works because it helps you move yourself along to try and, intervene. But you can do it at any rate. We'll kind of go through each of these. But most importantly, whatever you give for feedback and what your concerns are, you need to be specific, you need to be direct, and you need to be concise. So we're not hinting and hoping. You're going back to the Elaine Bromley video. We're not saying, oh, well, doctor, the tracheostomy pan is in the room, right? We don't want to hint and hope. And as I always say, if you're doing something like this with the 3 W's or the 4-step tool, do not be Midwestern nice. Don't sugarcoat it. Say exactly what you mean. Be very, very concise and direct so that there's no misinterpretation. What I'd really like for you to do if you could, it's not too much trouble. No, you can't do that. Okay, so this is a little video that was put together by, I can't remember what VA did this, Tampa, I think.
Let's do a timeout before proceeding with the procedure.
Let's go, come on.
No, sir, we have to do a timeout first. Just a moment, doctor. Dr. Oliveira, are you ready for the timeout?
Yes, I am. Listen, we were supposed to be in the room 15 minutes ago. I've got 30 patients in clinic. Look, you got the consent, got patient name on it, consent, patient's marked, let's go.
Dr. Akira, I can see that you don't want to do a proper timeout here. What I'm concerned about is without doing the proper universal protocol process, we are prone to medical errors, patient endangerment, and untoward outcomes. And what I want to do is do a proper timeout so we can properly identify the patient, identify the correct surgery, and identify the correct site of the surgery.
Look, we were supposed to be in the room 15 minutes ago. I've got 30 patients in clinic. Come on, you got the consent, has a patient name, patient's marked, inguinal hernia, let's go, knife.
Dr. Akira, I feel uncomfortable without doing the timeout. If you want, I can call Chris downstairs and tell him that you'll be running late. So that you're still here in surgery, that sounds good to you?
This is ridiculous. We all know this is a hernia repair. I need to get down to clinic. I'm the chief of surgery. Just give me the knife.
Okay, Dr. Oliveira, Liz, John, are you comfortable doing without the timeout?
Definitely, I don't feel comfortable with not doing the timeout.
No, we need a timeout.
No, I do not feel comfortable without the timeout.
This is ridiculous. This is just a hernia repair. I do not have time for this.
Well, I think Dr. Jakey is just next door. If you want, I can call her to help us solve this problem we're having right now.
No, you don't need to do that. All right, let's do the timeout.
All right, timeout.
What you have just seen is an example of a threat to error prevention. You have seen a way for members of the team to respectfully and professionally speak up and stop the line using the effective followership algorithm. If you see anything not right or not safe, you should state your concern specifically, directly, and concisely. Avoid hint and hope communication. Instead, use the 3 W's: what I see, what I'm concerned about, what I want. Also, utilize the 4-step tool: get attention, state concern, offer solution, and pose questions. Then you can engage the team and, if necessary, use the chain of command. On behalf of the surgery, anesthesia, and OR nursing staff, we thank you for your time. We hope you enjoyed the presentation.
All right, any initial thoughts about feelings about that video? Occasionally some people will make some remarks about the surgeon's sterile technique because he comes in and he pulls his gown up with bare hands. I would say this, and not being critical of the people in the video, but I think she got real close to being Midwestern nice there at the beginning. You know, she's kind of getting a little verbose and maybe not being, you know, kind of direct. But it, you know, to do something like that, it takes some bravery, right? You know, you're kind of fighting, you know, the chain of command, essentially, like the hierarchy in the operating room specifically. And so you've got to be, you know, you got to be brave to have to intervene in that respect. I will say my favorite part of that whole thing is when she, and we'll get to this slide in a second, is when she starts to recruit all the other people in the room to get on her side of the argument, right? Because now you're fighting this battle against more than one person. Now the surgeon's going against everyone in the room. And so it's a little easier to persuade someone to maybe at least consider what your concerns might be. So after we do the 3 W's, if you can't get the leadership attention, or they're not taking you seriously, then we escalate up to the next step, which is the 4-step tool. And so this works actually really great. This is like you think about when you were a kid, right? And, you know, your mother said, Robert Paul, that got my attention, right? Because nobody called me that unless I was in, you know, deep trouble. Same thing in a clinical environment or in the operating room or wherever. If someone calls, say, the physician or the director of the VA by their first name, that's kind of breaking the social norms. And so when that happens, that's an immediate attention getter. And then you state your concerns. I'm uncomfortable with whatever. I don't think this is okay. I'm not sure we should do this. You're stating what your concern is, and then you can offer them an alternative. I want to stop what we're doing and step back and let's just talk about this for a minute before we cause some harm, before we do something that's going to hurt somebody. I would also say that at the alternative point, you can also change want to need, right? Because then you're expressing this real desire, like, oh, listen, I need you to step away from that patient for a second and listen to me. And that, to me, always seems like it's a little bit more emphatic. And then, again, using the word us just gets everybody on the same kind of page. And then you can pose a question. And it could be something as simple as, would you like me to go order a chest x-ray? Or would you like me to draw an ABG? Or do you agree with me? Or can you see my point? Either of these 3 and 4 allow the person in the leadership position, it allows them to find a graceful exit from the road that they're on. Yeah, there you go. When your mom calls you by your full name. I was a towhead when I was a kid, but no. I was fatter than that. Okay, so then respectful escalation, and this is what we saw the OR nurse do so well. Right? The chief surgery wasn't listening, and he did have a little bit of a tantrum, but what she did well was she tried to use the first 2 steps, and then she was like, this is getting me nowhere, so now I'm going to start reaching out to the people around me who, you know, you could see the scrub tech, I'm assuming is who it was, who had the big eyes and was like in shock, like, it's what's going on. She knew immediately she had an ally there already, so she just reached across the table verbally to that person and said, do you agree that we should stop? And so basically it's the power of coercion, right? You get a room full of 5 people and it's 5 against 1. Well, maybe you just do stop for a second and reconsider your situation. And if you say, is anyone else uncomfortable with this? It allows maybe the people who are in that environment with you who may be unwilling to step up on their own, it gives them an opportunity to then jump on board, that they were not forced to take the action initially themselves because maybe they were uncomfortable doing so. And then take action. At a certain point, if harm is imminent, you have to act, right? You can't wait. Like, you're not going to stand around while a patient's arresting and have some philosophical debate about whether we should do X, Y, or Z. You're just going to jump on the chest and get started doing chest compressions because the situation requires you to just do it. You've talked about it long enough, and now things have gotten to a point where you have to engage. And then finally, the last option, which was also shown in the video, is respectfully escalating it by using your chain of command. Now, the important part of this is recognize that whatever the threat or the harmful situation or the potential risk, it's not going to go away by using the chain of command, but at least you've alerted somebody above you that this problem exists. You still are going to have to come back to the immediate moment where you have to engage and do something to avoid harm. But by using the chain of command, hopefully that causes some downstream changes so this doesn't happen again. So if you recall, when we ran through the effective followership, we all want to be up here where we're an independent critical thinker, but we're actively engaged. We're like Vijay Singh's caddy here. And so we've got all the information, but we're also utilizing the effective followership algorithm to help us out in a situation where we want to avoid harm. Because let's be honest, that's what this whole team's training is about. It's about, taking good care of the veterans. It's about safety, and it's about speaking up. So that's like the whole goal of everything we're doing, is to try and get people to be inspired to step up and do the right thing to try and save somebody from getting hurt. So we discussed 911 at the beginning. You may go your whole life never having to do the 3 W's, right? Just like some people have never called 911, you may never call 911. However, if you had to, you know what to do. You call 911, you tell them what you see, they decide if it's a real emergency when they get there. You don't have to describe to them what the fire is and what's burning. You just say, there's a fire at whatever. You don't have to know what it is. You don't have to know exactly how to deal with it. You're just describing the situation that you perceive as an emergency. Same thing with the 3 W's. What I see is this. What I am concerned about is this is going to result in harm to a veteran, and what I want is for that to not happen, and I want you to stop what you're doing so that no one gets injured. Anybody familiar with the bystander effect? Okay, another little piece of nerdy history for you. So this is like standard information in psychology textbooks. And this is a byproduct of an event where in Queens, I believe, a young woman was murdered in early 60s, I think 1964. And she got stabbed to death. And 2 weeks after the event happened, one of the New York papers, I believe it was the Times, published this sensational headline that said, 38 people witness young woman being murdered and nobody responded. So as a result of that, psychologists started investigating this event and how this could happen. And basically what they came up with is that people are less likely to intervene if there's people around who they think could intervene. Right? So the take home for us is, we're in a hospital, it's a big building, there's hundreds of people that are working here. It's much easier to see something and not say anything because you think, well, somebody else will say something, or you make an excuse, right? So I'm too busy. I'm sure somebody already called 911. I'm sure they're fine. I like this one. Yeah, they're probably just drunk. That doesn't work here. But essentially that's the bystander effect, is that based on the theory that 38 people ignored these women's cries because they assumed somebody else was making the phone call. Now, a little debunking of the folklore of this. The Times actually, people have investigated the incident and everything. If there was nowhere close to like 38 people that were even aware that it was going on. The Times just wanted to have a nice big splashy headline to sell a lot of papers. But even though that was a complete farce, this research in psychology came out, and so it was the knock-on effect was that this is actually really some solid research. But bottom line is, don't assume somebody else is going to make the call. And again, you have to be brave to step up and intervene, especially if you're working against the hierarchy gradient, in your department or in your institution. So just remember, we want people to speak up. We want people to express concerns. It's not about the person who's making the argument. It's not about their position in the system. It's about the argument that they're making. That's the most important part. That's it. Now that we've gone through all of this and kind of talked about it and implementing some of this, what do you see in the 3 W's that you would be worried about, like that might be a stumbling block or some sort of impasse to you using this?
I mean, for myself, like I would never say that to like a doctor.
Okay. Anybody else?
Well, I don't know about anyone else, but nobody speaks like that.
Okay.
But what I want, sometimes I don't know what I want.
Sound like my wife. Okay.
I'd be maybe afraid I'd get in trouble.
Okay. And I think those are all very realistic observations, right? We'll start with Debbie. Nobody talks like this. 100% accurate. But I think that's the perverse beauty of it, right? Because it's so weird that as soon as you hear the first part of that, hey, listen, what I see is whatever. What I want is that I don't want to do this. Or what I'm concerned about, rather, and what I want. Now, you don't have to know exactly what you want, because you can say, what I see is this patient's in trouble, and I'm afraid if we keep going the way we're going, things are going to get worse, and I'm concerned about this patient being harmed. You don't have to know exactly what it is you want beyond saying, what I want is for us to just stop for a minute and talk about this. And I think the concern about speaking to someone like above your place in the hierarchy of the institution kind of goes back to your concern about, I'd be worried that I would get in trouble. And I would suggest that if you use the 3 W's, it almost eliminates the risk of you getting in trouble for what you're saying. It's basically like calling 911. There's no danger in calling 911 if your intentions are pure. There should be no consequences of using the 3 W's if it's a patient safety event. So you shouldn't have to worry about offending the doctor, especially if the doctor is going to do something that's going to cause a veteran harm. You shouldn't be concerned about saying something to the director if the director is doing something that you consider potentially harmful. You shouldn't worry about retaliation because you're following the playbook for patient safety. It sounds totally weird, but that's why it would work. Because, if I say what I see, what I'm concerned about, and what I want, that's SOS. That's Mayday. That's 911. That's stop the line. It's weird, but it's no weirder than 911 probably was in 1979. And now you don't even think about it. So, in a generation, or in 10 years, or 15 years, the 3 W's will be so standardized across the health system that no one will even give it a consideration. Finito.